Thank you so much. It's really great to be here and such a great meeting. Really appreciate being a part of this. So let me just go ahead and share my screen here. Right. So I get a very different topic, which is really important one, and I think very complementary to what we just heard from Dr. Manis and Dr. Becker. But this is a tough one. It's sort of the idea of how to make decisions and how to think about making decisions and who to make those decisions with after a person has been diagnosed with AML. So, I think that one of the first things to consider is, of course, what the goals are. And Dr. Manis sort of talked about this because, there are situations in which AML can be cured. And of course, for patients and families and for us as well, that's always what we want to do if that is a possibility. And so, how to get to a cure is something that should be discussed or considered even on the first day of diagnosis, really. And so, there are times in which a cure is possible with the standard sort of intensive chemotherapy and then further cycles of treatment that we call consolidation alone. Those are unusual. Those are the exception. But when those are on the table, then, depending on a patient's ability to withstand that degree of treatment intensity, that is something to be considered. And then, the majority of the time in our field, patients can really only be, or most reliably be cured with an allogeneic stem cell transplant. And, that is not something that can be done from the very beginning. That's, as you learned, something that really is only possible once a patient achieves a remission. And, the better the remission, the deeper the remission, the better the potential outcomes for, having that transplant work. There are. But I think those are sort of the very different directions that a patient can take, with respect to curing this disease. Many times a cure is really not a possibility. Maybe because of a patient's inability to tolerate a stem cell transplant, or maybe a patient is unable to get their disease into a remission. And so those are sort of different scenarios that have to be sort of taken as they come over time. Sometimes it's not possible to assess when a person's first diagnosed if they might be future candidates for a transplant, because when we see a patient at their very on day one of their diagnosis, usually because of this disease, they don't feel very well. They may not have very good organ function. And there may be a lot of other factors that are inherent to the disease that are complicating the assessment of whether a patient could at some point potentially tolerate a stem cell transplant. And so oftentimes those questions can't even be answered until later, until you kind of hopefully are able to get the disease under control or into a remission. And then, the eligibility for a transplant should be reassessed at that point. And then a final word on this is that, as you heard, based on the sort of decision-making around people who might be cured with chemotherapy alone versus people who might be cured with a transplant, that information is very important, but isn't all sort of available on the first day of a diagnosis. So some of the information really that gets to all the personalized biology that Dr. Becker talked about, sometimes that is not available or trickles out over the course of days or weeks after the initial diagnostic bone marrow biopsy. And the disease biology, as well as the patient's sort of fitness or ability to withstand treatment, are both, I would say, equally relevant in crafting a treatment strategy. And both of those are not necessarily known factors on the day of the diagnosis. So obviously, this is a complicated question, and it, like so many things with AML, it does require, treatment at an experienced center with people who deal with this disease often. There's a lot of nuances to these decisions that are best made by experienced, health team members. I think that's an important principle that, when possible, and Dr. Manis mentioned this, the idea of a second opinion, or management at a center that has a high volume of this disease are important for those reasons. So just to kind of take it back, that was a very broad overview, but step one would be, okay, do good risk factors exist that might allow a patient to be cured without a transplant? In other words, just chemotherapy alone. Like I said before, this is uncommon, but you should be able to get most of this information back within a few days of the bone marrow biopsy. And so, what we say at this point is that in the rare occasion when this is relevant, it's 20% of younger AML patients have this favorable risk disease biology, but it's very rare in older patients, and the typical patient with AML is an older patient. And so this is not the most common scenario or situation that we face. But when we do, we want to make sure we know, because the treatment approach is very different. And so we'll take some patients who, may not be the ideal candidate for intensive induction chemotherapy, and recommend that nonetheless, if they have favorable risk disease biology, in the thinking that intensive induction chemotherapy represents the potential for a cure for their disease. And so for them, the risk is worth it. Whereas, an older patient who doesn't have that type of favorable risk disease biology, who can't necessarily be cured from intensive induction chemotherapy, we would not recommend that they undergo that type of a treatment, in the thinking that the risks associated with it, because it's not a curative regimen, are not worth it. So a lot of very kind of challenging calculations have to be made pretty quickly in these couple days after a diagnosis. And so what do we do if, let's say, a patient is not a good candidate for intensive induction chemotherapy, or in other cases would be unlikely to respond to intensive induction chemotherapy based on their disease biology? Then the first line, sort of less intensive regimen, that's the standard of care really, is, as you heard from Dr. Manis, this venetoclax-based regimen. So venetoclax plus a hypomethylating agent, azacitidine or decitabine, that's sort of become the standard of care really all over the world, as it's rolled out and been approved in many different places in the world for that scenario. So, the upfront goal of anything, of any scenario, whether you think a cure should be the goal or not, with treatment, should be getting into a remission. Once a patient's in a remission, this very, very aggressive and proliferative disease takes a break, you have a pause. Now, in most cases, if you do nothing more, it will come back. So it's a temporary remission, but it is a time in which you can allow patients to recover from toxicity that they encountered from their treatments. You can gather more information. You should have pretty much all the information back related to an individual's disease biology at this point. And then, really be able to make some decisions. So back to our initial conversation, once you're in a remission, a transplant is now medically possible. maybe the patient at this point appears to be a good candidate for a transplant. And maybe their disease biology is suggestive that they would benefit from that or could be cured by that. And really in those cases, as you heard before, the different risk groups, really what we're talking about are certainly the adverse risk group that we would recommend getting a transplant to have any chance of a cure or a long-term remission, but also potentially the intermediate risk group patients could be considered for transplant. I know at most of the higher volume centers, that's typically the recommendations that are being made for suitable candidates. Whereas, a patient who's not a candidate for a transplant once they're in a remission, and let's say, in the most common scenario was given the venetoclax-based regimen in that situation, we would recommend continuation of that treatment indefinitely, or until toxicity were to occur or disease recurrence or resistance. That's the sort of current recommendation, and it's sort of based on not having really anything better to recommend, not knowing if indefinite therapy is really the best thing. It's sort of the default thing that we do. So there's a lot of nuances that are necessary to consider in this type of a decision-making process. So the degree to which a patient's priority is on quality of life. Some patients would tell you that really the most important or only consideration is their quality of life. And they are willing to sort of trade the potential for survival, longer survival, even cure, for considerations related to their quality of life right now, today. And for some people, for different people, that means different things. For some people, it means, they want to continue to get blood transfusions, platelet transfusions, antibiotics if they get an infection, but maybe they don't want any more treatment or any treatment for their underlying disease. Other people would say that they don't want transfusion support. Other people would say they don't want to ever be admitted to the hospital. So there's sort of these red lines that are different for everybody. And then other people would say, the only thing that matters is the length of life that I can get. And I would sacrifice any degree of quality of life to just be able to live as long as possible. So it's a very personalized sort of decision. And I think that calculation impacts the upfront treatment strategy, what you do once in remission, and on and on. So, and it's dynamic. I mean, it could change between the time that a person's first diagnosed and once they hopefully get into remission, they might change their mind in terms of what their priorities are. So this is something that has to be sort of constantly reassessed. Other considerations, for some people, it's really a non-starter to have to spend weeks in the hospital, which is something that is typically recommended for intensive induction chemotherapy. And then for other people, that's not a consideration, or maybe that's an advantage because they don't want to try to be struggling in a home situation with their disease and caregiver issues, et cetera. And then, of course, like I mentioned before, I think, the type of hospital where this is occurring is a consideration. And so, the level of experience that the hospital has, I think, should be factored into the recommendations that people are getting from that team. And, this is a very difficult disease to get second opinions in because many times it is so aggressive and so sudden and causes so many sort of active life-threatening issues that, you don't have the luxury of sort of going to a different practice, a different doctor, or a different state to get another opinion, like you might with other types of very serious cancers or other medical problems. So many cases, patients and their families find that they really have to make the best of the environment that they are in. And, we on this call who treat patients in high volume centers would all advocate for having at least newly diagnosed acute leukemia patients be treated at such a center. If that's not possible because of safety issues from a transfer perspective or insurance issues, or, where I practice here, there's, hundreds and hundreds of miles between centers that sometimes it's just not safe to try to move patients over those distances who are that critical, then at least asking that maybe a consultation by phone between providers occur, so that somebody could, that maybe isn't as experienced treating acute leukemia, might be able to call a Dr. Becker, a Dr. Manis, and sort of get their thoughts on the situation and see if that might be possible. So that's definitely something patients and families can advocate for and ask, and often do, and I think should. So, that brings me to sort of my last slide here, and that's this concept of actively participating in the care of this disease. So, I mean, this is a huge challenge because given how rare this disease is, the lack of public awareness of it, most people and their families, when they're diagnosed, they know very little, if anything, about it. It's very scary. People know in general a leukemia, and something called an acute leukemia sounds, terrifying. But it's impossible to sort of expect you, a patient or family member, to get up to speed on this disease in any period of time that would be relevant to really, make a big impact. So, like I said, I think asking how much experience the team has with this disease is very reasonable. Asking, other consultations from higher volume centers, very reasonable. Sometimes even asking to be transferred to one of those centers. But it's so uniquely challenging here because, you don't hear about this disease in, the lay media. Very few people know anyone who's ever had it. And so I think there should be a lack of, people should not expect of themselves to become experts in this disease overnight, when diagnosed with it. And that's really an unreasonable expectation that people have. And if that's even attempted, then I think you're going to find a lot of frustration, because this disease has so many nuances. As you heard from Dr. Becker, it's so heterogeneous and different from case to case. So a good amount of trust in this one is necessary to have in your caregivers, especially at the time of diagnosis. And over the course of weeks, as you sort of settle into it, if appropriate, you can learn more and have some of those really good questions to ask. But I really struggle with sort of how to tell people they should interact with their healthcare providers at the very beginning, because you cannot expect a person to really have, great questions to ask on day one of this, or to be able to really fully comprehend how this happened and why it happened and what has happened. I think, sites like HealthTree are great at really assisting in this. But I would say, for patients and family members, really kind of give yourself a break on this, because it would be an impossibility to really expect this of yourself so quickly. So that's really what I had prepared, and I think that leaves us a good amount of time for Q&A, if that's okay.